starting only first para will tell him. No, mom, not yet. People are still coming.
Good morning, everyone. Shortly we are starting. I request everyone to gather back for the scientific session. I request all the delegates to kindly gather back for the scientific session. Thank you. I request all the delegates to occupy the seats. Soon the scientific session is going to start. Thank you.
Good morning to one and all present here. Imagine a world where healthcare is personalized, where diseases are preemptively thwarted, where aging is graceful, and whose well being is not a distant dream but an attainable reality. The world of physiology has been evolving at an astonishing pace, unlocking secrets of the human body that were once shrouded in mystery. Today, our aim is to shed light on these recent trends, empowering each one of us to make informed decisions, embrace a healthier, more fulfilling life. So without further ado, let us embark our journey to the scientific program of 34th Annual National Conference of the Physiological Society of India, Physicon-2023. So here I am Varshini Badgandi from 3rd phase MBBS.
And here I am Utkarsh Patil, a third phase MBBS student, here to take you on this scientific journey. To begin with, we have an oration lecture for which we invite Dr. R.V. Kulkarni Sir, Registrar, BLDE deemed to be University, to chair the session. We also request Honorable President and General Secretary of PSI to join the session and do the needful. Over to you, sir.
Over to you, sir.
Good morning. I heartily welcome you all to this first session. This session is Dr. S.C. Mahanabini's Memorial Oration. I request Professor K.K. Deepak to deliver the oration. Professor K.K. Deepak is currently working as a visiting professor at the Center for Biomedical Engineering at IIT, Delhi. He was a former dean and professor and head of the Department of Physiology at AIIMS, New Delhi. Professor Deepak is highly accomplished individual with an illustrious career in the field of physiology and biomedical engineering. He has been interested in space physiology for a long period of time and continued in contributing the same area. He has been associated with the Center for Biomedical Engineering since 1990s and actively contributing to various projects of biomedical engineering. Professor Deepak's passion for research and academia has led him to collaborate with several esteemed institutions, including various IITs and other engineering institutions. His contribution to the medical sciences, especially autonomic neurosciences, led to the establishment of first autonomic function lab in India in 1989 in AIIMS, New Delhi. He created manpower in the same field and technological developments. He has been working extensively in the domain of space physiology for over a period of decades, exploring crucial aspects of human adaptation and microgravity. Notably, he filed a patent for a gravitational loading body gear, pro-gravity body gear in 2016, which effectively creates gravity during microgravity exposure. The patent was later published in 2018. Professor Deepak is also a co-inventor for more 6 patents focusing on areas such as isometric exercises, human muscular fatigue, recording, and other space physiology related innovations. His team has developed an indigenous cloud-based system, centralized HIV systems. In 2000, he established India's first formal vascular functional lab in the Department of Physiology at AIIMS, New Delhi. Professor Deepak has received many awards, delivered several oration lectures, and being bestowed upon many fellowships in his entire career. For his immense lifetime contribution in the field of physiological sciences, the PSI is conferred him with prestigious Professor S.C. Mahanabini's Memorial Award 2023. With this brief introduction, I welcome Professor K.K. Deepak to
A.C. Mahalanobis, Professor A.C. Mahalanobis Oration is one of the prestigious oration of the Physiological Societies of India. Dr. A.C. Mahalanobis is the physiologist who introduced physiology in India after his complete education in the University of Edinburgh, UK. He was the fellow of the Edinburgh University. He has been given professorship of that university, but he left the job and came back to India and tried his level best to introduce physiology to teach in different institutes other than medical colleges. And he was the first president of the Physiological Societies of India, and when the journal has been introduced, he was very much present. Initially, he was the professor of physiology in Presidency College of Presidency University. Later on, he joined in the Department of Physiology, University of Calcutta. And especially this award is given to a pioneer physiologist of the country. And we have all of us have gone through, and many of us know about Professor K.K. Deepak. He is a pioneer physiologist of the country, and I can call him among the present legendaries. He is the #1 physiologist of the country. #1 physiologist of the country at present. So we feel honored to get Professor K.K. Deepak in this occasion, and we are proud that Professor K.K. Deepak has been awarded this prize. So he will be awarded with a He will be awarded with a medal of the Physiological Societies of India.
Hello. Actually, as a custom to rules of the PSI, this oration, any orations, actually followed by no questionnaire. So if you have any questions, you can contact Professor Deepak or all the recipients for all the rest after the session. Okay. So it's our respect to all the oration recipients. Thank you.
Thank you, PSI. Thank you, Professor Kushal Das. Thank you, Dr. Nayak, for nominating me. And I'm very happy to be here at BLDE University and really enjoying the environment and both the academics. So recently, February 2023, in UK, in the university, they have published about widely recognized physiologist of the country of India, Subodh Chandra Mahalanobis. So this is a very recent publication where they're saying the Indian scientists who were there, they were uncovered. And so this is already available in UK global press. So now, another 25 minutes, I have tasked to tell you about the functioning of the vessels and physiology. So it's a big work and long standing work. So I'll take the speed of Vande Bharat and the way I go, and so please be attentive and I'll tell you a couple of things. So vessels are important, we all know. And so I'm going to make a storyline which is all in one intermingled, how the mechanisms, how the modification intervention, how device development can be taken into a one platform, and we have done all in a one go. And how from the simple platform, the way Dr. Kushal Das has started vessel function from arsenic poison and another thing, you can take to the high tech, and those some of the examples I'm going to. So we started autonomous function in 1989, and we developed AFT testing. During the development AFT testing, we found vessels are very important, and without vessels function, we could not interpret autonomic functions. So we established in 2000 the first formal vascular function lab in the physiology department as an offshoot of autonomic function, so that we can interpret clinical interpretation of fall in BP or rise in heart rate both together. And then we developed several technologies related to that, which I am going to talk about. So this has been a little journey from a need and concept. There was a need for doing this vascular function testing, And then we collected data on local blood flow. And we went into indigenous development. And then we went into the peripheral and central blood flow development by using, and then mechanism elucidation of fibromyalgia, chronic kidney disease, myocardial infarction, pregnancy, induced hypertension, and blood volume changes by various methods, and diabetes mellitus and a metabolic syndrome. And over the years, starting from autonomic and then need, we developed high level signal processing now. Currently, we do very high level signal processing using ultrasound, try to see how my endothelial and inner lining are oscillating and do they reflect. So this is a long journey which we took, and several devices we try to develop our own, and that is a story. So this is a story like this. Started from autonomic, landed in vascular, used autonomic vascular to promote yoga research, fundamental research, and then using the same technology for space sciences. And that's how, because everything is one, physiology, physics, everything comes in one place when we talk of science. So innovations paved the path at each point. When we had nothing, we did innovation to do something. And we had something, now we're doing something more to do innovation too. So first I was encountered by Bach plethysmography equipment, which it's 2003, 2002 they have done it. This is a simple device which could measure the resistance or impedance. From impedance you quantify blood flow. Fine. This equipment was lying for 25 years in Bach, but never seen a validation. We took up a challenge. We took the equipment, put in our cath lab and physiology lab, and did a validation and showed that the validation measurement of cardiac output are the same as done by the Bach equipment. It's indigenous development we took out to the light. And then we took this equipment to cath lab. We did innovations how to put electrode for cardiac output, not the whole body, but a vertical. That was also published. And this was a simple setup. Then we asked why technology is lying in the cupboard. So after 25 years, we took up a challenge company called L&T. So you will see Dr. Patil sitting over there, Shri Tunul, president is sitting over there, the director sitting there, Dr. Ashima Patil sitting there, all HODs, Dr. BHU, you see so many HODs are sitting there. And in front of them, we did a transfer of technology of impedance plethysmography to the L&T Medical, big giant. And this equipment became a successful story now. It has started long back, but now this on the last, the Star 90 scan ray, which is housed in Mysore, it's a big company in Mysore, has actually selling this as a part of multifunction monitor. So this is an Indian story, and then this is a story for us also, because then we had a free of cost equipment coming from Bach us to do research. See, it's a win-win situation, so we could run it, and we could do so many publications made in India. No foreign equipment, everything's from India, the idea is from India, and this is how we have done publication on blood flow measurement. And this is single story which I'm going to, just a beginning of this. So this is how. Then using other equipment like FinaPress and using ECG and simple devices, from ECG traces, from blood pressure traces, we could quantify the relationship of bioreflex sensitivity. Because you get ECG and blood pressure, you can do that. And this is what we did. So we quantified bioreflex sensitivity. We entered into endothelial function by simply measurement devices by using ultrasound. So we had struggled and we got the P&DT certificate ourselves. We can do ultrasound, and this is very clear. So in physiology, ultrasound is being used for recording blood vessels. And so this is what we could. Endothelial function is simple, easy. How much vasodilatation is there, you can quantify by imaging, by using ultrasound, and you can determine the percentage, and you can induce vasodilatation by cuff occlusion for 5 minutes. You release it, you know it, reactive hyperemia. So this is physiology, well-known physiology. We applied to the clinical sciences, and then we started doing endothelial function 20 years ago, and regularly this is being done in our laboratory. Then we also, this is how you can measure and quantify, and then you can do a normalized. So it's very very simple to do endothelial function measurement. Then we measured arterial stiffness by doing a pulse wave analysis. So if you take a pulse, carotid pulse, or if you take a radial pulse, and from there you try to find out, do a wave analysis, and from there you can find out arterial stiffness by doing pulse wave velocity. Doesn't require much stuff, very simple. Simply you can do this, and then you can determine augmentation index. If you know my central pressure, how do you know my central pressure? I know my brachial pressure. From brachial pressure I can do a transform function, and from there function, because it's a known circuit, you can know the central aortic pressure, and that's what we did. So this is what we had equipment, quick acquisition of equipment from the very simple to this. I tell you how simple things are and they can be done. You know, the stiffer arteries, they leads to a lot of problems, and this is a metabolic syndrome problem. Everybody knows it. But if you look at the pulse wave velocity, you can do many analysis. If you do simple amplitude analysis, it gives you a lot of information. So those who are having, say they have nothing, but they have pulse wave analysis at their back end, like PPG, and from PPG itself you can do wonderful research. I'll let you know how you can do simple amplitude. So once you know, you can characterize the PPG, and this PPG can be characterized by simple parameters, by diameter, or by, you can also know the stroke output or ejection period. From there you know the functioning of heart. So you know the condition of the heart and the vessels. So what stimulus can you give? Cold pressure stimulus. It increases your blood pressure. There is a vasoconstriction. The moment you have vasoconstriction, your amplitude will change, and from there you can find out. Another test you can use, which we have used, this venous occlusion and arterial occlusion, and therefore it will give you differential changes in waveforms, and this is how you can look like a venous occlusion on the top, arterial occlusion on the top, and look at how they differ, how pulse waveform differ. So this can be measured by a simple PPG available across the street. PPG is very common after the COVID, this has come. And therefore, we did beat to beat analysis. Once you have PPG, you do beat to beat analysis and try to find out what is the baseline and how they are changing. On that basis, we have proven that amplitude and slope, they reflect diameter of vasculature. That's what we wanted. Pulse travel time, how much time it's taking to travel from here when tagged with the ECG, you can know the tone of vasculature. And these are the two important parameters which we derived very simple, low-cost equipment. Anybody can do it. So that's what you should start doing by this. We published two beautiful papers. This is person Nandakumar Selvaraj is from IIT PhD, working in our laboratory 2008. And 2011, we published two papers, monitoring of reactive hyperemia using PPG amplitude and transit time. So you can still, this is a golden test, golden tool available across the country. We also showed influence of respiratory rate on variability of blood volumes and pulse. So this is pure physiology we're doing to make us confident that what we are doing is good, the tool is good, and then we are ready to go to use in clinical scenario. And therefore we went into kind of in a high mode to do a clinical research to find out. So we found out which is the condition will give you sure short vascular changes. We took Cushing syndrome, hypercortisolism. So one of the first MD student, Dinu S. Chandan, who joined us, I said, this is a difficult topic, nobody has done it. We have pulse wave analysis, you have Cushing syndrome. Join the hand with the endocrinology department, and we did. He's a wonderful guy, and we measured non-invasive assessment of vascular function. Using all simple tools which you have in your laboratory now. PPG is available, ECG is available, nothing else is required. Only one IIT person or some analysis required. And we measured cortisol and other parameters, and this is simple design, simple equipment, but we published beautiful papers out of it. We showed that in the control versus endogenous, the amplitude is decreased. And we also showed that in the two, when you normalize decreased reactive hyperemia, we showed when you clamp vessels, the reactive hyperemia is much less in Cushing syndrome, which means the vessels are not dilating. That is the important point. Vessels are not dilating, it's a serious problem for them. And that's what we proven by simple paper, and we published two beautiful papers, very well cited. Simple technique, very low cost, nothing, almost nothing, And this is simply understood physiology applied to Cushing syndrome. Then we took up several diseases. The time does not permit me, I will only permit me only for another 12 minutes. We have 4 things to offer, like vascular function studies in ESRD, kidney disease CKD, and also renal transplantation. Diabetes mellitus left and right. We started with the diabetes mellitus on the day 1, metabolic syndrome and pregnancy induced hypertension. They all are very well published, available, and this is what we did last 20 years and kept on doing. Quickly I'll again go and quickly tell you about the story about each. CKRD, there is a cardiac problem in kidney diseases, well known. Now what is the possible reason? So we did understood that there is a forward wave and the reflected wave. If we do analysis, we can try to find out the problem, the insult of the vessels, and we also did pulse wave velocity. We determined from carotid to radial, carotid to femoral, and try to find out the difference, and then you can know the central vessels and peripheral vessels, and therefore we did, and we showed that pulse wave velocity in patient is much more here. And then we also showed that there is a loss of baroflex function. We had a continuous BP monitor, ECG, and we found, and we correlate the two. And that's what we could show that. But is it because of some local changes, uremia or CKD, it has a lot of problem, or it is some true reflection of a cause-effect relationship? Then we took up in the same scenario, same renal nephrology department, we said, can we do it on renal transplantation? And we did. We showed the result before transplantation and after transplantation, and then we published beautiful papers like this. Reduction in augmentation index after successful renal transplantation. And also renal transplantation normalizes baroflex sensitivity through the improvement of central arterial stiffness. We measured central arterial stiffness by a simple technique. Therefore, it's a, when you put a kidney back, its cardiovascular system becomes better. Therefore, it will not have a heart attack. So it's a beautiful fundamental research from physiology point of view, also fundamental research from clinical application. So this was the second application. Then we took up diabetes mellitus again in a big way. We took up, and then we measured, transcranial Doppler, and we measured the brain blood flow, the middle cerebral artery blood flow, and tried to see the flow, find out how is cerebral. And then we change cerebral blood flow by giving a physiological stimulus, well known to physiologists than anybody else, like rebreathing, carbon dioxide, or breath holding. And by this, we showed that this is how we did it. It's very simple. Put ultrasound probe here and just get the signal acquisition for 10 seconds each. You have the vessels blood flow, middle cerebral artery blood flow. And then you give a rebreathing circuit already available in physiology. It has been used by anesthesia people some point of time. And this is a very simple, one cylinder and one controller. Anybody can make it. We made it ourselves. We could get beautiful record of middle cerebral artery blood flow. And we saw the effect of rebreathing, CO2, and also, and then we found when we give this, blood pressure changes. So are our changes because of change in blood pressure or because of the per se disease? Then we did a correction in blood pressure, and we found that correction of the blood pressure improves correlation between cerebrovascular reactivity assessed by breath holding and CO2. So it becomes a beautiful test. You change, you control the blood pressure, you normalize. And so this itself became a paper. Then we concluded cerebrovascular reactivity is impaired in all patients of type 2 diabetes. This first report came up, and then again then we also looked for the systemic vascular reactivity. So we are talking of cerebral vascular activity and system are the same or the different. This is a physiological question. So we looked for the systemic vascular reactivity. We also found this is change, and we found that systemic vascular reactivity is normal in 50% and impaired in 50% of patients for type 2 diabetes. So therefore, the sensitivity peripheral and central is different. Again, this we published it. And then we correlated with the HOMA insulin resistance, which is a standard test for beta cell function. insulin response. And then we found that there is a correlation between the two, and this is how we could prove. Then we moved to the metabolic syndrome, and considering the metabolic syndrome and both other things are related, diabetes or MI or other thing. So we took a metabolic syndrome by a clear definition, and then took out who got coronary heart disease or who do not. They have metabolic syndrome with and without CAD, and then we measured all risk factors, and then again we did endothelial function measurement by reactive hyperemia or occluding arteries for 5 minutes and relieving it and see how they dilate. And this dilatation was measured by ultrasound. And therefore, we found that FMD was lower in CAD group, which means metabolic syndrome whose FMD is lower are going to get heart attack. Very simple equation. And we could do it. And so this is how this again was published in Diabetes Vascular Diseases. And then we took up diabetes in a bigger way. In a diabetes, along the line you develop hypertension. So the newly diagnosed hypertensive subjects we took, and we caught them immediately from the OPD on day 1. It was a difficult exercise, but we did that exercise. Try to see when you give intervention by giving angiotensin ACE inhibition, how do they affect autonomic, vascular, endothelial, metabolic, biochemical profile? And that's what we wanted to fix the mechanism, how it is. And we did 2 publications in this line. Prachi did PhD with us, and the 2 very well cited, the impact factor 10, the last paper is available. So we could show it. Look at the title, imbalance between angiotensin 2 and angiotensin 1 and 7, that's a balance system, is associated with the vascular endothelial dysfunction. First line. Second line, improvement in angiotensin 1, 7 precedes and correlates with the improvement in arterial stiffness. So the 2 fundamental things are being correlated and showing that this is what is happening in them when they get first time hypertension. And that's how we could show it. So if you look at overview, I'll just run quickly. We took a diabetes with hypertension. We took all cardiovascular diseases, and we know in the body there's a beautiful balance available between pro-inflammatory and anti-inflammatory. And the whole lot of physiological sequence starting from sympathetic versus parasympathetic, sympathetic low or high, vasoconstriction, pro-inflammatory, proliferative events, oxidative stress, fibrosis, anti-fibrosis, hypertrophic, anti-hyper, they all are there. The beautiful mechanism available to give you a balance in life. And we were looking for what is happening to this balance in all these measures. So we did measurement of all. So we wanted to evaluate its effect on this. It's a design which is a difficult design. We did measure all, including renin-angiotensin, ACE2, angio 17, bradykinin, VCAM, E-selectin, HSRP, IL-10. We all measured all this along with vascular and autonomic function. Our sample size was 67, but we scanned 1,345 patients. Go to the OPD and find out who's got first time hypertension, who fits to our criteria. And that's what we could get this kind of figure. And then we analyzed the results, effect of ACE inhibition on brachial blood pressure. The brachial blood pressure decreased after 1 week and 3 months of ACE inhibition. That's why it is being used clinically, the best possible treatment. Central blood pressure decreased after 1 and 3 weeks after ACE inhibition, that we measured. Time domain indices of HRV, which indicates parasympathetic function, increased after 1 week and 3 months. So my parasympathetic is becoming better and better function. VLF and HRV increased after 1 week of ACE inhibition. This is the first time we did 20 minutes HRV to quantify honestly the VLF function, because VLF is a slow wave, and this is what we did. High frequency of HRV increased after 1 week and 3 months, and also total power. Baroflex sensitivity increased after 1 and 3 months. So ACE inhibition is doing very good physiological changes. That's why it's a good treatment. Any treatment which is helping physiology is always a good treatment. If it's not helping, only helping symptoms, no, that's not the good, correct. Peripheral arterial stiffness decreased after 1 week and 3 months of ACE inhibition. Central arterial stiffness decreased after 1 week and 3 months of ACE inhibition. Endothelial function improved after 1 week and 3 months of ACE inhibition. So the beautiful result we got, and this is kind of a summary we could get it, and we could clearly spell out our objectives which have been met, and therefore we could propose to the world the mechanism of disease pathogenesis of hypertension development in diabetes mellitus and its prevention by ACE inhibition, how it is. So therefore we could see positive and negative association with the different factors which I enlisted before. Then we also correlated this with clinical parameters. It's not only physiological parameters I'm talking of clinical parameters, all parameters which are related to hyperglycemia and clinical manifestation, including the lipid profile. And therefore we could propose the mechanism beautifully. We could say that this is all stars which are shown here are a contribution to the mechanism known. So therefore we could see that how the ACE inhibition of Ang1, 7 and Ang2 balance, which is off balance, now becomes favorable balance, tilted towards favor, and this includes. So therefore it improved autonomic function and it decreased the risk of cardiovascular diseases. That's how it connects to the metabolic syndrome. So now coming to the last leg, I'll take 1 minute to come. We applied the same thing to the more serious problem of preeclampsia, and then we had a more problem because 7 to 8% only were getting patients out. So we have to screen 4,000 patients in order to get some number. We measured all parameters, including the biochemical marker like ADMA, asymmetric dimethyl arginine, placental growth factor, PIGF, and pentraxin, and therefore we come out and we concluded that semester-wise prediction of preeclampsia development, and we were very successful in creating that model. And so first trimester prediction is by ADMA and pentraxin and BRS, bioflex sensitivity. Second, endothelial function. Third trimester, arterial stiffness. And we concluded that in a combination one can predict even in a first trimester whether the lady is going to develop preeclampsia or not, because once it is developed it is a serious problem. These publications are available on my website. So this is one published in pregnancy hypertension, in another vascular medicine. We got a huge data and then we went on, and then we are still continuing this research with one more PhD student at ESIC Faridabad. We have taken up the forward, so we are not stopping here. So this is the last thing, and talk about the endothelial function. What new? We told you about FMD, flow mediated dilatation. Now is the reverse true? Low flow mediated constriction. So when we need dilatation, it should dilate, but when I need constriction, it should constrict. Is it happening? How to quantify? It's got some relevance. So currently we are focusing on this research. So we use the same tool. You block blood pressure cuff in the forearm occlusion, and this, from the occlusion there will be some point of time there is a blood flow decreased. When you release it, blood flow is increased. So you get two phases. During the two phases you measure the diameter and see the low flow mediated vasoconstriction, and it's quantifiable. We say it's quantifiable. You can find out the least diameter and the diameter at baseline and then find out the percentage. That's how you get it, and then it's easy. So and why it is, because you have blood flow, blood is flowing like this, blood is also flowing like this in a pathological condition. If I sit for a long time on a chair, if I don't do exercise, I become hypertensive, blood also flies because of the retrograde flow. It strikes with some other point. And therefore, there is a balance between anti-atherogenic and pro-atherogenic balances which are determined by anterograde flow and reverse flow. And this is called low flow mediated vasoconstriction, quantified by ultrasound. So we did it, and we correlated with restricting retrograde flow associated with endothelial dysfunction. We did it in right hand, left hand, and different normative values, and we published that work. Smriti Badwa, now she works in France, Paris, very famous research institute, and this is very easy to do. Forward wave, backward wave, quantify, and then you plot the curve, final curve, delta pressure curve. And this is what you get. Baseline when you do occlusion. And so therefore by this, LFMC may indicate early endothelial dysfunction. Now we are saying endothelial function you can find out by FMD, but if it's happening early, LFMC, low flow mediated vasoconstriction, you can quantify, do they constrict or not? I need both constriction and dilatation. That's how. So we could show low flow mediated constriction is associated with cardiovascular disease severity. We quantify disease severity by plotting all parameters. In a metabolic syndrome, people having CAD and non-CAD, and try to find out that yes, FMD is related to my carotid radial pulse wave velocity, and it is also related to in early to LFMC. And so now we just come to the conclusion. We did a lot of patent filing related to the devices. Some of them are related to vascular function. The left one we published using a fuzzy logic. If I have to set my blood pressure, say after operation or something, blood pressure is rising, like then how to give a dose. So it can be done by a computer fuzzy logic, input and output relationship. So this is done with the IIT. Then we also did a novel BP device. This is the first Indian device, NIBP, with the IIT Delhi. We could use tonometry technology, and we develop our own device. So this is a theoretical paper on this. This is what the device we developed with the help of IIT Delhi, and we need a team. We need cardiologists, physiologists, and engineers, and that's how the team. Only then you can do a little big thing. Alone we can do something, but so this is what the theme of the conference, and bench to bedside, or from experimental to laboratory, and that's what. So feedback is important. You go to the clinical side, what has been talked in the morning introduction, you go to the clinical side and let them come, and then try to find out. Go to the engineering, do a cross-border talk, and never hesitate to talk anyone. So with that, I come here. Thank you so much.
I request PSI President and General Secretary to present the citation to the speaker. Thank you, sir, for enlightening us. We also request the PSI President and General Secretary to present the memento and certificate to the Chairperson, Dr. R.V. Kulkarni, sir. Thank you, sir.
Moving on, I am pleased to invite our next eminent speaker, Dr. S.S. Gowda sir, to present his keynote address on the topic Research Evidence for Improving Maternal and Newborn Health Outcomes in Resource-Poor Settings. Now, I politely request Dr. Shailaja Bidri ma'am, Professor and HOD of OBG Department, Shri B.M. Patil Medical College, Hospital and Research Center, Vijayapura, and Dr. Rajesh Honudgi sir, Medical Superintendent, Shri B.M. Patil Medical College, Hospital and Research Center, Vijayapura, to chair the sessions. Over to you, sir.
Good morning. It is my proud privilege to introduce our esteemed mentor for research and Dr. Shiva Prasad Gowda, Professor of Physiology, Jawaharlal Nehru Medical College and Director Research, KLE Academy of Higher Center, Higher Education and Research, International Principal Investigator for NICHD, Global Network for Women's and Children Health Research, Director WHO Collaborating Center for Research in Maternal and Perinatal Health, Nodal Officer, ICMR, Center for Clinical Trials, Belgavi, Karnataka, India. Research areas are postpartum hemorrhage, maternal and infant nutrition, pregnancy anemia, hypertensive disorders in pregnancy, maternal and neonatal sepsis, cervical cancer, intrapartum labor care, birth asphyxia, preterm births, low birth weight infant feeding and growth, understanding adverse outcome of pregnancy, early childhood neurodevelopment, impact of COVID-19 on maternal and newborn health outcomes. Developed research collaboration with a number of international academic partners from USA, Canada, UK, Australia, Africa and South Asia, and 20 academic research centers in 6 states of India. Research grants from NIH, WHO, UK, MRC, AAP, BMGP, BMGF, Tracer Health Fund, CIFF and DBT and Goal. Honorary member of American Academy of Pediatrics, Newton Prize for Research Excellence and Innovation for Evaluation of Novel Device in Management of Hypertension and Shock in Pregnancy in Low Resource Settings. He published 258 peer-reviewed publications with a high H index of 40. Sir, over to you.
Thank you so much. I have a special relation with BLDE. In the last 3 months, I got 3 invitations to present in 3 national conferences that are being held in October, November, and December. I would have presented the same talk in any of these 3. I missed the first one. I'll probably miss the third one. So it is destiny that has brought me to the physiology platform. And I count it as my luck, because I am basically a physiologist. But the work that I am presenting represents a collaboration between basic sciences, clinical departments, and a host of other entities. So this is truly collaborative research. What was being mentioned in the inauguration by the Vice Chancellor and others. And this is particularly relevant for the physiology community here, that unless we step out of the 4 walls of our department, we will not make any significant difference. So at the outset, I bring greetings to you all from my institution, Jain Medical College, and the KLE Academy of Research and Higher Education. And the presentation is about the work that has been done by our group. So all those 258 publications and H index of 40 is not mine, it is collective. I have absolutely no claim on them as an individual, it's the team. Over the years, our unit has got recognition from multiple entities as a center. We started in 2001 with the Global Network for Women's and Children's Health Research from the National Institute of Child Health and Human Development. Then subsequently, WHO recognized us as a collaborating center, and then more recently, ICMR Center for Clinical Trials and a Center of Excellence, and the Australian National Health and Medical Research Council is also recognized as a Center of Excellence. And it is the support from all these entities that has made the work possible. So as I said, we started with one area, postpartum hemorrhage, way back in 2001. And over the last 22, 23 years, the portfolio has expanded to practically encompass major causes of mortality of mothers and children. So what I'm sharing with you this afternoon is some of the work and the implications of that work in terms of public health policy, as to how it has tried to impact the survival of mothers and children in low resource settings. One of the things that we have been running, and this is the longest running protocol of a unit, started from 2008. So it's 15 years now since the registry is ongoing. It's a prospective cohort that we run in geographical areas, now only in Belgaum. Earlier we used to have clusters in Bagalkot district as well. Basically trying to register every pregnancy of women residing in a defined geographical area and then tracking their outcomes at delivery and 6 weeks postpartum. Both looking at hard outcomes like mortality as well as morbidity characteristics, predisposing factors to those adverse pregnancy outcomes, as well as some health system indicators in terms of where are these women delivering, who is delivering them, what is the C-section rate, etc., etc. So this sort of acts as a platform for most of our community-based research. Not only is it a data gathering tool, but also tells us what the problems are, what interventions are needed, and then we also use it to capture the outcome of interventions done in these communities. So as of now, we are hopeful that in the next 1 year, we'll hit the 1 million mark in terms of the pregnancies across the global network. And our own contribution from India is around a third, with Belgaum itself contributing around 22% of the whole database. So it's a rich database and it is available in the public domain. US government has a policy that any federally funded project, the data should be accessible in the public domain. So it is in the public domain. People can access this database, do any kind of secondary analysis. All that you need is approach the data coordinating center. As I said, the first project that we implemented was looking at using prostaglandin like misoprostol for the prevention of postpartum hemorrhage. This is the first community-based placebo-controlled RCT for the prevention of postpartum hemorrhage. This was done from 2001 to 2006, and we were able to show that with the use of prophylactic single dose 600 micrograms of misoprostol, you are able to reduce PPH by 50%. And as part of that protocol, we developed a blood monitoring or the collection device, because till that time there was no tool to estimate the actual blood loss. Whatever was being recorded is visual estimation, and which can be anywhere. So we developed this device, and subsequently has been used in a number of research studies, and it is biodegradable. So you don't have to worry about environmental issues as far as this device is concerned. It can be used in any setting, even on the floor. So there are ties which help you to tie it to the abdomen. Of course, subsequently the drug has got into almost every single guideline that counts as far as PPH prevention strategies are concerned. It's registered in multiple countries, is available in generic form now. When we did the trial, only Cytotec Searle was the sole manufacturer. But now the generic version is available, and that brings the cost down. And even people have attempted home distribution. Give it to the mother during her pregnancy so that no matter where she delivers, by whom she delivers, she has access to this drug. She can take it on her own practically and help in controlling or reducing the blood loss. But the challenge with misoprostol is that because it's prostaglandin, has certain adverse reactions, and people keep pushing us back saying that, can you have something else? And that is where the heat-stable carbetocin came up, which is an oxytocin analog with a slight modification to the oxytocin molecule for the prevention of postpartum hemorrhage. And WHO initiated a large multi-center trial. We were the lead for the India site. Vijayapura was one of the centers in that study as well. And so we showed that this heat-stable oxytocin is non-inferior to oxytocin, but takes out the whole equation of cold chain storage during transport and administration. And the company had made a pledge that if the trial is positive, they will offer it to the public sector health facilities at the same cost as oxytocin, but minus the cost of the cold chain transportation. So it actually comes out cheaper than oxytocin if you really work it out. Of course, subsequently it has been included in, again, a number of guidelines and recommendations. We had the fortune of launching the product from our hospital in 2021. And to put this in context, in the last 30 years, there are only 2 drugs that have been developed that relate to pregnancy-related condition, and carbetocin is one of them. There's not much research going on in this area because pregnant women are considered as special population or vulnerable population. So there's not much of drug discovery going on, even though there are a number of conditions that do require medical interventions. So this is an area that needs a lot of more emphasis and research. And now it is gradually getting into the national approvals from multiple countries. And this is just a story of the last 1 year. Now, hypertensive disorders of pregnancy is another area, and I'm glad I'm following Deepak, because I have a few ideas and questions that may relate to the work that he is doing, and it was a wonderful presentation. Now, we started out doing a community level intervention by training ASHA workers, the community health workers, to record blood pressure during pregnancy at multiple time points, and then gave them a blood pressure device that has been developed by the King's College group along with us. This is the only validated blood pressure monitoring device for pregnancy. There is no other device which has been validated during pregnancy. It is semi-automated. It calculates shock index, so it has these traffic light signals which alerts both hypertension and hypotension. And you need not be even a very literate person. All that you need to do is apply the cuff and inflate it. It is semi-deflating cuff. Automatic deflating cuff. And we gave these ASHA workers a mobile app to guide the management. if you find hypertension and proteinuria, what you should do. Does it require immediate referral or can the woman wait? So that kind of a decision tray is built in the app. And so basically what we are looking at is, if a woman develops preeclampsia, should the pregnancy continue, which is the classical model, the expected management, or should the pregnancy be terminated? Terminated when I say, should the baby be delivered and taken care of in a NICU? What is the trade-off? So we did this study, and what we found is, between the immediate delivery versus the expected management, the gain in gestational age is only 3 days. By expected management, you're not really prolonging the labor for weeks. There's only a 3-day difference. The stillbirths can be reduced by immediate delivery. The only thing is you need good NICU support to take care of preterm babies, which in any case, any baby delivering in any setting deserves. So rather than compromising the mother, compromising the baby by prolonging the pregnancy, I think it makes sense to deliver the woman as soon as she develops preeclampsia. And we started looking at the causes of stillbirths and preterm neonatal deaths. So we looked, and this was done in Davangere with our colleagues there. So we looked at 5,000, and the group in Karachi, in Aga Khan University. So we have 3,000 preterm deliveries, out of which 400 stillbirths and 400 neonatal deaths. And we did the whole placental histopathology, PCR of and we did, autopsy is not accepted much, especially clinical autopsy in fetuses. So we did what is called as a MITS, or a minimally invasive tissue sampling, and then used PCR to understand the infectious disease profile. The main finding that comes out is that there is maternal vascular malperfusion that is the leading cause to many of these adverse pregnancy outcomes. And this is where I think the challenge is. How can we diagnose that vascular malperfusion even when the pregnancy is ongoing? How early we can detect it? Are there biochemical markers like placental growth factor which can be used? And if so, how can we intervene to delay the end of the pregnancy or a preterm birth and improve the outcomes? If somebody can answer this question, I'm 100% sure it's a Nobel Prize winning research. So there's a big question here, and 13% of our deliveries are preterm across the globe. Whether it is low resource setting or high resource setting doesn't make any difference. So there's a huge burden, and many of those preterm births, the mortality rates are high. So if you can fix preterm birth, you can fix neonatal mortality and stillbirth in a big way. So one intervention that we have tried out is this low-dose aspirin supplementation during pregnancy, starting from around 10 weeks of gestation and continuing up to 34 weeks, daily single dose 75 milligram. And we were able to show that A, there is a reduction in perinatal mortality, B, reduction in preterm births, and decrease in preterm preeclampsia. We are looking at other candidate interventions, including statins. But statins have their own issues. So can we find the right statin is the question. Another intervention that has been tried out in preterm births to improve newborn survival is the antenatal corticosteroid administration, which has been in practice for more than 50 years. So we initially started out saying that, all right, here is an intervention which has been out there, we are not scaling it up, let's take it to the community and see whether we can improve the coverage. we're not questioning the ability or the efficacy of the drug, but more, can we improve the coverage? We were able to increase the coverage, but at the end we found that in some groups, the mortality actually went up rather than a reduction. So then we started thinking, what is going on? If the woman doesn't deliver preterm and continues her pregnancy, she has an elevated chance of developing sepsis. And that in turn can also contribute to increased neonatal mortality. So WHO said, wait, let us not scale it up across resource poor settings. We need more research. They amended the guideline and also initiated a trial looking at dexamethasone in the early preterm, 26 to 34 weekers. So what that study showed is that there can be a benefit only if you can provide good obstetric care, good neonatal care in terms of feeding, thermoregulation, respiratory support, basic essential newborn care. Then only you can improve survival. Just giving steroid in as a standalone intervention, there is absolutely no benefit. In fact, you may be causing more harm. So right now we are doing another study where we are trying to see whether we can reduce the dosage of the steroid without losing the efficacy. A low-dose betamethasone regime compared to the standard dexamethasone regime is the comparison. We are about 40% into the recruitment. Hopefully the trial will end somewhere late 2024 or early 2025. Nutrition is another area that we have been working on. And the focus has been on iron, zinc, and selenium. And most of the deficiency is not something that happens when the woman becomes pregnant. She carries the deficiency from the preconception into the pregnancy and then in turn also compromises the baby. So we looked at whether a preconception supplementation for at least 3 months using a simple soybean peanut milk preparation can address this issue. So one arm got the supplement 3 months prior to conception, one arm from 3rd month of pregnancy onwards, and the other arm got the routine IFA supplementation. So the bottom line is that whether you supplement prior to conception or during pregnancy, you can improve the outcomes by reducing stunting and SGA babies. So that's the outcome of this work. And the more deficient the woman, the more benefit you're likely to get. Anemia is another area that has defied solutions for a number of years. India was probably one of the first countries to start IFA supplementation during pregnancy way back in the 1950s. And even if you look at the NFHS 5 data, we see that during pregnancy, the moderate rates of anemia are somewhere 45 to 50%. That means routine oral IFA supplementation is not working. Women don't consume iron orally. So we are looking at a single dose IV iron supplementation just after the first trimester at 14 to 17 weeks of gestation. And then we are trying to see whether compared to the daily IFA supplementation, this group does better. We are in the last phase of the data collection now. By March 2024, we'll end the study. We did it in 3 districts in Karnataka and 1 district in Rajasthan, in Jaipur, where the burden of moderate anemia is very high. So we've enrolled more than 4,300 women, and we are following up for pregnancy outcomes and the postpartum 6-week follow-up. And we have been fortunate to get funding to extend that cohort to look at the effect of that IV iron on brain development at 12 and 24 months of life. And a sub-study that is using MRI to really understand what is the influence of iron supplementation on brain development. So both these studies are ongoing. So in the next couple of years, I think there will be a lot of data coming from all these three studies, which will help inform policy on whether oral IFA supplementation should be continued or we need to switch. Last year, we completed another study looking at neonatal sepsis, and again, Vijayapura was one of the centers that participated in that study. Using a single dose azithromycin, 2 gram, 500 milligram, 4 tablets, given just before delivery. And we found that there's a significant reduction in maternal sepsis and maternal mortality. The trial was stopped. They said, you're not going to get any benefit in terms of reduction in neonatal mortality or neonatal sepsis, but you have a clear benefit in terms of maternal mortality and maternal sepsis. So we're now trying to work with the ministry whether we can scale it up as a routine prophylaxis. There's one project that I've really loved in the last 20 years of my public health research career, and that is this study looking at training community-level birth attendants for newborn resuscitation using bag and mask ventilation. This is between 2006 and 2012, when 70% of the deliveries used to be at home conducted by traditional birth attendants with very high early neonatal mortality. So we trained a large pool of traditional birth attendants to do Apgar scoring. These are illiterate, so they have to learn to count till 10. They have to appreciate tachycardia versus bradycardia using a stethoscope. And if the baby has any signs of respiratory depression after birth, initiate bag and mask ventilation. And we were able to show a 40% reduction in neonatal mortality by training these guys. This is a big lesson for medical education. We think that, we can't teach people. People are willing to teach if we are ready to teach them. Now, the problem is with us, not with them, not with the learner. The problem is always with the teacher. So the AAP finally ended up revising the whole curriculum, came up with a simplified version called as Helping Babies Breathe. No need for endotracheal intubation, no need for chest compression, no need for any chemical stimulants. Just a simple bag and mask ventilation can reduce. I know I'm closing out in 2 minutes. I'm aware of the time. So it's got incorporated in even the national guidelines for training birth attendants for newborn resuscitation. There was a big consortium that rolled it out in multiple countries across Africa and many of the other low-resource settings. And it's not always the Secretary of Health, who is the equivalent of the health minister, to come down to a primary health center in a remote corner of Belgaum and meet the birth attendants who participated in this study. I'll skip this part. We did 2 studies on COVID-19. Many of these papers are published, so you can look at what are the correlation between exposure to COVID-19 and pregnancy outcome. There were some adverse effects associated with that exposure to COVID-19. All this has been possible because of the support from all of the funders that we have received, and of course, a big team that works behind me. I'm only the face. I get the credit, but the work is done by them. So I'm highly obliged to all of those people, right from an ASHA worker working in a remote village to all my collaborators in international organizations. It's because of their effort that all this has been made possible. And once again, I thank the organizing committee, Dr. Sumangala, Dr. Lata, Kusal, my good friend. for giving me an opportunity to share the work that has been done by our group, and I look forward to talking to Deepak to see if we can fix that preeclampsia thing. So thank you so much.
Sir, thank you for this nice presentation and sharing your wonderful work which you have been doing for last so many years, which have changed the lives of so many mothers and babies, and which has created a social impact, and it has definitely a role model for many of the physiologists who can go in the preventive and social medicine and do the work which change the lives of the people, sir. Thank you for sharing your wonderful work again for you and your team. 1 or 2 questions are invited because of lack of time. Otherwise, you can share his work or you can discuss during his lunchtime.
Yeah.
Yes, sir. Yes.
Thank you, Professor Gowda. It is wonderful. It's really an amazing part of the story. And I'm proud personally as a physiologist and Physiological Society of India proud that you are a life member of Physiological Society of India in that respect, that you did a wonderful job. You have shown the physiologists that actually the grassroots work where it can go to the actually applied aspect. This theme is perfectly matched with your talk. Exactly the bench to bedside, how it goes, it is said. Only one thing, yes, I want to ask you, as you have really asked a question and doubt about, when WHO also said that whether the early detection of the preeclampsia can be determined or not, and some of the aspects. Have you tried with the insulin-like growth factors or the VEGF-A receptors in the serum? If it is possible, then it can be blood only, by ELISA it can be measured, or any other chemical analysis from the blood, no tissue samples required. Have you tried, or are you anybody doing on this regard? Because I'm concerned with the insulin-like growth factors here. Placental growth factor is also one of the classic example in that.
Right. People have looked at multiple predictors, and right now we don't have a definitive answer that this is the one single marker for predicting preterm birth. Placental growth factor appears to be the most promising right now, and there's a body of evidence that is gathered. And we just got funded, and BLDE will be one of the sites for that study, looking at placental growth factor and then deciding the course of pregnancy depending on the level of placental growth factor. We may combine it with ultrasound examination of the placenta to look at the volume, Doppler flow and all that. We just got funded. We haven't worked out the details of the protocol. I'll be more than happy to take up some sub-studies within that cohort. This will be again a multi-center trial in Karnataka, in Odisha, in Rajasthan and UP. So we'll have a huge population base and a patient pool.
Yes, because normally physiologically it's said that the moment there is starting, the human chorionic gonadotropin arises, immediately it reflected with the erosion of the vessels from the blood in the smooth muscles, and that vascular changes occurred in the presence is genetically controlled, and that is actually the time when blood pressure, everything is normal, but level of HCG may be high, level of insulin-led growth factor may be higher, specifically placental growth factor.
Actually, there's
still not placenta completely formed, just early.
There's been a study in the South Asian population residing in London. They have looked at placental growth factors, and the levels of placental growth factor in the South Asian population are different from the other races. So there is something going on there.
Chances are there.
Even anecdotally, if you go to Ballari-Raichur belt, the rates of preeclampsia are extremely high. If you want to do a study on preeclampsia in this part of the world, go to those places because the prevalence is so high. So there is some genetic factor, there is environmental factor. Heat stress is also more there, and heat stress is also being associated with multiple pregnancy outcomes, adverse outcomes. So environmental factors, nutrition is a problem there. So we don't know. And it's a big area that needs to be researched, and it can have a huge impact globally because the burden is so much. So,
Thank you very much.
Thank you for your knowledgeable words, sir. I request the chairpersons to present the certificate and the memento to the speaker. Thank you, sir and ma'am. Now, I sincerely request our beloved principal, Dr. Arvind Patil, sir, to present the certificate and the memento to the chairpersons, Dr. Shailaja Bidri, ma'am, and Dr. Rajesh Manutki, sir. Thank you, sir.
First one? Short. This one? Short. This is? Yes. One minute. This is forward, sir.
I kindly request delegates to keep their mobile phones on silent mode.
This is backward.
Thank you.
This is forward. Yes. This is backward. This is backward. And backward.
Now, I would like to invite our next illustrious speaker, Dr. Amar K. Chandra Sir, UGC Emeritus Professor, University of Kolkata, to deliver the plenary lecture on cyanogenic plants and their impact in public health during post-salt iodization phase. I modestly request the chairpersons, Dr. Subhash Chimkode Sir, BIMS, Bidar, and Dr. Kiran Chulki Sir, Cardiologist, Shri B.M. Patil Medical College, Hospital and Research Center, Vijayapura, to chair the session. Thank you, sir. Over to you, sir.
I welcome Dr. Amar Chandra, sir, the former professor, head of the Department of Physiology, as well as Senate member, University of Calcutta. He is an internationally reputed scientist. He has long-standing research as well as teaching experiences. His studies cover epidemiological studies to molecular biology. He published more than 100 original articles in national and international peer, completed 18 original research projects, supervised 24 PhDs and 80 MSc projects. He has been elected fellow, National Academy of Medical Sciences, India, and UGC Emeritus Professor. Besides academic attainment, Dr. Chandra is the President, Physiology Society of India, General Secretary, Federation of India Physiological Societies, and Advisor, South Asian Association of Physiologists, and its founder member. Sir, over to you, sir, for your presentation.
Good evening Good afternoon to all of you. Thanks to the chair for your nice presentation. And I am honored here to be a speaker in this session. My interest, I used to do endocrine physiology. My special interest is on thyroid physiology with some reproductive endocrinology. My lecture is on, today's lecture is on cyanogenic plants and its impact in health during post-salt iodization phase. This is my lecture, that is how certain plants, there are certain plants, they metabolize, they gives nutrition, and they also produces certain products named as thiocyanate. The plants that are capable of producing thiocyanates are called cyanogenic plants. And these plants has important role on public health. Basically, they have adverse role. I am discussing especially this point, that is the involvement of certain plants in causing thyroid disorder. To get entry into the thyroid physiology, goiter is the best model. We are well aware about the development of goiter, that is the enlargement of the gland, that is the enlargement of the thyroid gland at the neck, and its basic physiology is that there is a axis that is called hypothalamus, anterior pituitary, and thyroid axis. From hypothalamus release TRH, anterior pituitary, then anterior pituitary stimulate TSH. TSH then acts on thyroid gland to produce T3 and T4. And for the synthesis of thyroid hormone, it requires iodine. In absence of iodine, proper amount of T3, T4 are not produced. As a result, a condition prevails. That is, low T4 and T3 stimulates hypothalamus, that stimulates anterior pituitary, and that stimulates thyroid gland. As a result, the gland becomes more and more enlarged in size. It is the basic physiology of the gland, of thyroid gland, that is in iodine deficient environment, there develops enlargement of the thyroid gland or goiter. And we have also shown the picture, picture of histology of thyroid gland in the different stage. And what are the consequences of iodine deficiency? Why you are so serious about the iodine deficiency? That is, these are the common pictures. Goiter is the most common symptom. There occurs hypothyroidism, there occurs cretinism, reproductive failure, childhood mortality, mental deficiency, and if a community suffers from iodine deficiency, there occurs socioeconomic retardation. These are the common features, and for that, Government of India has taken the policy for the universal salt iodization, that is, iodine will be supplemented to all the iodine deficient areas to prevent and combat iodine deficiency. And after supplementing iodine, there are pioneering works. This work is in China. There we found that initially goiter prevalence was 80%, but after supplementation iodine, within 6 years, the goiter prevalence has reduced. In this way, cretinism prevalence, school ranking, and other prevalence has been decreased after the supplementation of salt. These are the pioneering works. This gentleman has been suffering from goiter. After using iodide salt, his goiter size has been regressed. It has been shown in the picture. And it is a rare picture. It shows that both the father and the mother were cretin. One neurological cretin, father, and mother was myxedematous cretin. And there it was the physiology before iodine supplementation. After iodine supplementation, we find they got married, and we find that their children are normal. All this clearly shows that supplementation of iodine has been established that all the iodine deficiency effects have been prevented. But our experience is quite different. What is our observation? Basically, our study is in the eastern and northeastern India. What we find in post-salt iodization scenario in certain areas. This is the picture of Tripura. If you see the neck of all the children. If you see that. If you see the neck of the child, school children, then you will find that they are not normal, they have been enlarged. In spite of the supplementation of iodine, that is after proper iodine intake. It is also the picture of Manipur, Northeast India. If you see the neck, you will find that their thyroid gland has been little bit enlarged. That is, these are called goiter. I have shown the picture of goiter, that is a large goiter. These are also goiter, and ultimately they will take the shape of large goiter. This is the children of Manipur. All of them have enlarged thyroid, that is goiter. The same picture, it is not only restricted in northeastern India, in Uttar Pradesh we found this type of picture, that is, it is the picture of Siddharnagar district, Uttar Pradesh. All the pictures are during post-salt iodization phase, and these are the tribal men and women, and their thyroid gland enlargement in spite of the intake of iodized salt. So what is your experience is that Government of India, Health Department think that after supplementation of the iodine, goiter will be prevented. But our observation is that even after supplementation of iodine, even after intake of adequate iodine, the goiter prevails. So, our baseline study reveals that consumption of certain plant foods and water is responsible for the development of goiter in spite of the intake of adequate iodine. In addition to that, if the consumption of iodine be more, then it also enlarges thyroid gland. And consumption of certain other factors present in the environment, they are also responsible for the development of goiter. So, there is a class of food, these are called goitrogenic food, they develop goiter. Goitrogenic plants and water. And our observation is that there are certain plants belong to the cruciferous group. They are called cyanogenic plants. They are capable of producing goiter. In addition to that, flavonoids containing food are also responsible for the development of goiter. Besides these plant foods, hard water, lithium, excess iodine, nitrate, E. coli, they are also responsible for the development of goiter. And this belongs to the cyanogenic plant group. That is on metabolism. These are cassava, available everywhere, sweet potato, sweet corn, mustard seeds, bamboo shoot, turnip, spinach, cabbage, cauliflower. All these foods belongs to cyanogenic plant foods. They are capable of producing thiocyanate as a product of metabolism. Their consumption may produce disorder of thyroid gland. But it should be keep in mind that in all the areas, the concentration of the cyanogenic constitution in these plants are not uniform. It varies from region to region. If we measure the goitrogenic content, cyanogenic constituent of this plant food in the southern India or northern India or northeast India, we will find that the concentration of the goitrogenic constitution is much more in the northeastern region, in the Uttar Pradesh, in the Sundarban Delta, and so on. So all the foods do not bear the same concentration in almost all the areas. Most of the work, because in the northeast region, bamboo shoot is used very much. So bamboo shoot, the middle one, it is used very much. So our work, we have done work almost all the plant foods, but we will concentrate our work on bamboo shoots. So thiocyanate concentration found, and because our preliminary study shows that the thiocyanate concentration, how much this food is consumed by the people, It is studied by measuring the urinary iodine concentration. And if we get the urinary iodine thiocyanate concentration in the urine is high, then we can say that their consumption of cyanogenic plant food is high. Thiocyanate, isothiocyanate, they originate from the cyanogenic plant foods. We are giving one example, that is bamboo shoot, how they causes enlargement of the thyroid gland and what is the mechanism for the development of thyroid physiology. So these are the bamboo plants. This grows everywhere, particularly in North India. Its growth is much, much more. And these are after just they are growing in the rainy season, they are collected by the women in the market and they used as food. And these are the bamboo shoots, and it is taken in a high sophisticated way. It is available in the market in this way, and for its taste, it is consumed by many people, not only in India but in other foreign countries, and it is a very tasty food, and it is liked by all. And if you visit particularly northeastern state, you will find that the ladies are sitting in the market and they are consuming, they are selling bamboo shoots. These are the bamboo shoots market by the side of the road. These are the bamboo shoot market. It is our observation. We have studied all this. So these are the one thing must be important in thyroid physiology, that there are a number of enzymes. There are a number of enzymes, that is sodium, potassium, ATPase, that helps in the transport of iodine. Because I have discussed that for the synthesis of iodine, for the synthesis of thyroid hormone, iodine is essential. Iodine gets entered into the thyroid gland, and for the purpose, it requires sodium, potassium, ATPase. It facilitates the entry of iodine from extracellular fluid or from blood to the thyroid follicular cell. This is the mechanism, that is, there is a transporter system that called NIS. NIS is a transporter that mediates the transport of iodine from the outside of the thyroid follicular cell to the thyroid gland. And this is another enzyme, thyroid peroxidase. All of you are well aware about the thyroid physiology biosynthesis. Thyroid peroxidase, TPO, another enzyme. It is very important. And there is another thyroglobulin. It is one of the important constituents for the thyroid hormone synthesis. And this is pendrin. And there are other factors. So our target is that after consumption of the cyanogenic plant foods, thyroid hormone synthesis is reduced. How thyroid hormone synthesis is reduced? So we have studied all the factors. That is, we studied the activity of these enzymes after feeding the bamboo shoot extract or cyanogenic plant foods, and what are the results. I am presenting on the following slide. That is, effect of cyanogenic plant foods, bamboo shoot, on thyroid hormone synthesizing enzymes and regulatory proteins with and without iodine. Because iodine is used for the prevention of antithyroidal activity, so for the purpose, simultaneously we introduced cyanogenic plant foods, bamboo shoots, and iodine. And what are the results are that? That is, first of all, we analyzed the phytochemical analysis of bamboo shoot, and we found that bamboo shoot contains sufficient amount of, it is our biochemical study, bamboo shoot contains thiocyanate, glucosinolates, and cyanogenic glucosides. These are the major constituent of bamboo shoot. And we did it phytochemical analysis by liquid chromatography. We are not able to find out the exact cyanogenic glycoside present in it, but we found the precursor and the metabolic end product of cyanogenic glycosides in bamboo shoots. So what is your observation is that we used 3 doses of bamboo shoots below the IC50 and found that a time and dose dependent significant decrease in the activities of sodium, potassium, ATPase. We shown the figure that sodium, potassium ATPase is an important enzyme for the transport of iodine. Its activity is reduced. The activity of thyroid peroxidase, another important regulatory enzyme for the synthesis of thyroid hormone, its activity is also reduced. Deiodinase, another important enzyme for the conversion of T4 to T3. Because T4 is not active, T3 is active, its activity is also reduced. So we all studied the activity of this enzyme we found that the activity of this enzyme is reduced. This study we have done on cultured thyroid cells, because we have collected the thyroid gland from the animal model, we cultured it, and in the cultured thyroid cell, we exposed bamboo shoot in different concentration, and we found to decrease the activity at different levels. And effects of bamboo shoot protein expression. We studied. These are the proteins, important enzymes. Sodium iodide is important. It is important. Thyroid peroxidase, pendrin, another protein. It facilitates the entry of iodine from the follicular, from the colloid to the apical cells. Thyroglobulin. All these are the important enzymes. We studied the activity of the enzymes after supplementing different doses of bamboo shoot, and we showed the picture as bamboo shoot extract at different 3 concentration with and without iodine. And our observation is that all the expression that is niche, TPO, pendrin, TG expression in vitro studies after 48 hours, 24 hours and 48 hours, their activity decreased. This is the this is our study, and our observation. So on protein, this is our observation. Just I have told you, and protein expression of niche and TPO decreases dose dependently and significantly after exposure of the bamboo shoot extract. If we add iodine in the medium, we showed partial prevention, but it is not completely prevented. Similarly, thyroglobulin and pendrin are closely associated with the thyroid hormone synthesis, and we found that their activity is also decreased after the exposure of the bamboo shoot extract. And the next set, we studied the gene expression of the important thyroid hormone synthesizing enzyme, and our study is that alteration of the mRNA expression of the niche TPO, thyroglobulin, pendrin, MCT8, one of the important factor for the transport of thyroid hormone, PAX8, important factor for the thyroid hormone synthesis. The expression of the gene of all these enzymes has been decreased dose dependently. We exposed the extract for 24 hours. In the culture medium, we exposed the dose for the 24 hours, 48 hours, with and without addition of, with and without iodine, and we found that in every case, their activity, their expression, mRNA expression has been reduced. In the earlier slide, we have shown the protein expression of these important factors or enzymes, and gene expression of all these important regulatory enzymes and factor for the synthesis of thyroid hormone has been reduced markedly. So our observation is that the expression of niche and TPO is impaired both in the 48 hours exposure study. Supplementation of iodine is unable to prevent it. Similarly, PDS, another important enzyme, monocarboxylase, MCT8, PAX8, all the activities of all these factors, expression of this at the genetic level has been reduced after the exposure of bamboo shoot extract. And this is another study that all this activity of all this enzyme is decreased. But what is the condition of the environment of thyroid cell, environment of the thyroid cell? That is what is happening within the thyroid cell, for which the expression of this enzyme has been decreased. And for the purpose, we studied the generation of ROS in this cell in different condition. The picture shows in control condition, 24-hour study, 48-hour study, and after exposure of different doses D1, D2, D3 bamboo shoot extract, and with D1, D2, D3 with iodine we have supplemented, and we found that we have clearly represented that all the indices of the ROS has been increased, and that is H2O2 production has been increased. This is one of the important part of the ROS. And what is our observation? That maximal ROS was produced after 48 hours of exposure of the thyrocyte under the influence of the highest dose of bamboo shoot extract, while there was dose-dependent significant increase. That is, ROS is increased. We used the NAC, whether the ROS effect is genuine or not, to check it. We added thyroid stimulating hormone in the medium, and we found that the ROS level remains high. That is, all the reactive oxygen species has been increased under the influence of the bamboo shoot extract. That is, the cellular environment of the thyrocyte has been changed after the intake of bamboo shoot. But it is not the intake, it is just the in vitro study using thyroid cells. And bamboo shoot extracellular changes including antioxidant status, lipid peroxidation, nitric oxide level. In addition to the antioxidant, we studied the lipid peroxidation, nitric oxide levels in the thyroid follicular cells in culture, and these are our observation. That is the activity of that is the dose-dependent decrease SOD and catalase which prevent antioxidant activity. Their activity is reduced. GSA, GPX level were also observed, have significant decreased, and there was a correspondingly dose-dependent significant increase in the lipid peroxidation as evidenced by MDA levels. All these are the details of the experimental. I am not interested to show you. You will not be interested. But one thing is that after the exposure of bamboo shoot, all the factors has been increased, and if we add iodine in the medium, it is not able to combat this. This is the lactate dehydrogenase DNA damage, and what are the happenings? That is, lactic dehydrogenase level increased significantly, DNA damage also decreased significantly, and DNA oxidation has all been increased after the exposure of the bamboo shoot extract in the thyroid culture media. And we also studied the cell cycle, and what we find is that there are lots of disturbances occurs in the cell cycle. If we see the numbers in the lower diagram, we find that the cell cycle has also been arrested under the influence of the bamboo shoot extract. In addition, we have studied BAX, PCL2 and P53, and we studied changes. That is, these are the changes. Increase in raw cell with cellular and DNA damage indicates towards changes in the cell cycle. Bamboo shoot extract altered normal cell cycle pattern of thyrocytes. BAX and P53 levels increase while BCL2 increased dose dependently under the influence of bamboo shoot extract. The close association of cell proliferation and apoptosis. We showed that after the consumption of the cyanogenic plant foods, for example, bamboo shoot, there develops goiter. What is the basic cause for that? We found that activity of the enzymes has been decreased, which are responsible for the synthesis of thyroid hormone. In addition to that, there develops an oxidant state in the thyroid follicles that prevents the thyroid cell growth, thyroid cell for proliferation and so on, and there is a close association of proliferation and apoptosis of goiter formation. This is responsible for the development of goiter. So this is the antithyroid constitution. It is a decrease in sodium potassium activity, dose dependent increase in reactive oxygen species, all this activity of the enzyme, impaired antioxidant status with increased LPO and nitric oxide level. This is also increased, I have shown it. DNA damage oxidation, increased LDH levels, decrease in PAX8. PAX8 is one of the important factors for the thyroid hormone synthesis. Its expression was also decreased. Decrease in NIS expression, decrease in TPO expression, decrease in thyroglobulin and MC8 expression. These are the MC8 is one of the important transporter for the transport of thyroid hormone, and decrease in pendrin expression, iodine entry inhibition, and disturbances in the thyroid hormone synthesis and secretion. That is all the major regulatory factors which are concerned with thyroid hormone synthesis, that is thyroid hormone synthesizing enzymes and other transcription factors. All the activities of this decreased under the influence of bamboo shoot, rather under the influence of the cyanogenic plant foods. And all these are responsible for the development of hypothyroidism initially, biochemical hypothyroidism initially, then anatomical hypothyroidism, that is called goiter development. So amyloidation and limited recovery of all factors on exogenous iodine supplementation. If we think that all the abnormalities that develop after consumption of cyanogenic plant foods, it will be covered by iodine supplementation. But in all the cases, we supplemented iodine. We exposed extra iodine with the cyanogenic plant foods, for example, bamboo. We found that there occurs prevention, but the prevention is little bit. The disease or the abnormalities remain same. So this is the possible mechanism, that is the cyanogenic plant foods. If it is consumed in excess amount, it will produce reactive oxygen species, excess H2O2, and this excess reactive oxygen species and H2O2 decreases most of the regulatory enzymes, transporting factor, and causing goiter or hypothyroidism. If we supplemented iodine, there occurs certain prevention. All the point that has been discussed has been shown in these pictures. So this is the picture. One thing is that goiter is the most important clinical manifestation of thyroid physiology. But what happens to the population? It is very important. That is, after the consumption of cyanogenic plant food causes goiter, one factor. Goiter is okay. But what happens to the goiterous population? Whether it is the end, there is no study in this regard. So we have studied extensive epidemiological study that goiter is prevalent in those areas where consumption of cyanogenic plant food is increased, in addition to the intake of additional iodine, that is iodide salt is implemented. However, the goiter prevails, and what happens to the goiterous population? These are the common autoimmune disease, that is Graves' disease and Hashimoto's thyroid disease. For the time constant, it is not possible to discuss all the points. What is the fate of the goiterous population in Manipur? In the Manipur, what we did is that in Manipur, bamboo shoot is consumed largely. So we have selected an assembly constituency area. That assembly constituency, this is the Graves' disease, this is the Hashimoto's disease. These are the common symptoms of hypothyroidism or those who suffer from thyroid disorder. We have studied all this. That is, we have selected a population in a constituent area. We measured goiter, that is enlargement of the thyroid gland by palpation method. We measured the urinary iodine and thiocyanate, whether their urinary iodine nutrition is normal or not.
Sir, just a gentle reminder about the time.
Thiocyanate, thyroid hormone, anti-TPO antibody, ultrasonographic study, fine needle aspiration study. These are the studies we have conducted. This is ultrasonographic study of the thyroid population. This is the fine needle inspiration. We have collected the specimen from the thyroid gland and we studied it. And we are not going in details. We have conducted the studies in 4 areas in assembly constituency, and our result has been summarized. And their urinary iodine content, thiocyanate content, and we shown, and their uptake of iodine level have shown it. Their TSH, free T4 and free T3 level, all these studies. So these are our results. We are not interested. And what is our observation is that FNHC study clearly shows that among the goiterous population, colloid goiter, lymphocytic thyroiditis, Hashimoto's thyroiditis, autoimmune...
Sir, sorry to interrupt. Sir, time is very short. One more lecture is
there. This is the last one.
Thank you very much. Thank you.
That is, these are all the occurrence of the different type of thyroiditis of the population. These are the pictures we are for the time constants, because it is a large study. So in post-salt, this is the last slide. In the post-salt iodization phase, the goiterous population, especially children and women of northeast India, are exposed additional environmental factors, relatively excess iodine, because they consume iodide salt and they consume cyanogenic plant food from where thiocyanate originate, that triggers the risk for the development of autoimmune thyroid disorders in their later stages of life, as evidenced by the TPO and TG antibodies, ultrasonographic and FNHC test. So, thank you. It is a large study. It is a part study, but to present the entire study as a whole is a time-consuming factor. So, as far as in brief, I have discussed all the points. So, these are almost all the works has been published, and these are our publications. And we got funding from DBT Government of India, DST Government of India, UGC Government of India, and these are the research scholars. Basically, there are many research scholarly groups, and they are associated with me for their work. So, this is the result. So, if you have any question, you can discuss with me in later on. Thank you. Thank you all for your patience sharing.
Thank you, Professor Amarchandra, for the elegant talk. It was an eye-opener on a lot of things, like for clinicians who are interested in treating the disease. but research in the public health arena can find out the causes and how effectively can implement the government plans and prevent development of disease like goiter. Thank you so much. Any questions I think can be discussed at the time of lunch, just for the time constraint. Thank you so much, sir.
Thank you, sir. It was very insightful. May I now request the chairpersons to present the certificate and mementos to the speaker. Thank you, sir. I also request Dr. Salim Dhunsi, sir, Professor, Department of Physiology, Alamein Medical College, Vijayapura, to present the certificate and memento to the chairpersons. Thank you, sir.
Moving on, I humbly request Dr. Tejaswini Vallabh ma'am, Professor, Department of Surgery, Shri B.M. Patil Medical College, Hospital and Research Center, Vijayapura, and Dr. Vidya Patil ma'am, Professor, Department of Anesthesiology, Shri B.M. Patil Medical College, Hospital and Research Center, Vijayapura, to chair the sessions. And now I request Dr. Vinuta Shankar ma'am, SUMC Kolar, to present a lecture on the topic Bridging the Gap, Strategies for Synchronizing Physiology Education with Competency-Based Medical Education. Now, I request the chairpersons to take over the further proceedings.
A very good afternoon, everyone. I am thankful for the opportunity of introducing today's speaker, Dr. Vinuta Shankar. Madam is a professor, Department of Physiology, Director, University Center for Health Professionals Education. She is also the Vice Principal of SDUMC. That is Devraj's Academy of Higher Education and Research Center, Kolar. Madam's major achievements are many. She is a member of BOS and Academic Council. She is a PhD guide in Physiology and Health Professionals Education. She has been adjunct faculty, Department of Medical Education, St. John's Medical College, Bengaluru. She is also a faculty, a FEMR and PSGFRI, Coimbatore. She has organized International Health Professions Education Conference with national and international speakers, and she has also taken part in pre-conference workshops. She has delivered many guest lectures and conducted workshops in health professions education events and national and international conferences. She has been a resource person in physiology conferences, summits and workshops. She has organized International Student Research Conference, DEMEDECON, from 2014 to 2018. She has been a member of National Academy of Medical Sciences, and she's also a fellow IFI Philadelphia. She has 56 research publications in index journals to her credit. Here I present Dr. Vinuta Shankar.
Thank you. So I will promise you that 5 minutes I will deduct from my session duration and will not stand between you and the lunch. So the session that I have been asked to engage you in is totally, there's a paradigm shift between what I'll be talking today in these 20 minutes as compared to what my eminent physiologist spoke. I'll be talking from the aspect of a physiologist who is an educationist. So I bring greetings from Devaraja's Academy of Higher Education and Research. And I'm talking to you about bridging the gap. So what is the gap that I'm talking about? The gap is, all of us know that physiology education is moving towards competency-based medical education. So we being taught in the era of traditional education, how are we trying to deliver and bring about Indian medical graduates who are having the capacity to be an accomplished clinician. So contemporary training is what all of us in the audience, most of us in the audience underwent. So at the end of the MBBS, we thought we are at the peak, we have done it all. And the reality is when we set to practice, we realized that the peak was somewhere different and we have a long distance to cover. So the whole thing is like, okay, competency-based medical education has been brought about in the regulation. So what if it just appears on paper and what if we continue to do the same thing? I'm reminded of Einstein who said doing the same thing over and over again and expecting different results is nothing close to insanity. So we have to change, and where does the change come from? So is it just the policy makers who brought about the change, or is it we the teachers who are responsible to bring in the change, to bring about Indian medical graduates who demonstrate a change different from those who were products of traditional curriculum? So for that, we need to understand what was curriculum per se. So we also ended out to be good doctors. But what drew curriculum? So curriculum was handed over on a platter and teachers delivered what was delivered to them. But in the current context, health needs, like the earlier speakers talked about the health needs. So now when you saw about how vascular functions and maternal functions, and when Sir talked about a lot of maternal mortality rates. So you know what is it that has to come in the curriculum. So it is the health needs that have been established that should seek priority areas in the curriculum. So curriculum, to start off, comes from health needs and health systems. And then the competencies that we need to tackle such issues is something that comes out as competencies. And finally, curriculum is drafted based on these health needs. So this is the shift that I'm talking about, and this is the shift that we have to bridge the gap from. So it is not only CBME, we are also, the onus lies on us to be aligned with WFME. All of us know World Federation of Medical Education is a body that has accredited National Medical Council, and so our graduates are now, what do you say, they can go and practice in US or Australia or wherever it is. That means they are eligible to take up competitive exams there. If we were not accredited, we were debarred from taking up competitive exams there. So World Federation of Medical Education has a set of criteria that we have to accomplish, and NMC, the National Medical Council, has maintained those standards, and we have got this accreditation thanks to NMC. So CBME is all in alignment with WFME. So here we talk about, we consider competence as achievement. So I think all of you know about this tea bag model. So what does this tea bag model say? If you just sip this tea bag in water for a definite period of time, you get good tea. But is competency like that? Does it mean that if I cover 4.5 years in a medical school, do I churn out a good Indian medical graduate? That is the question. So educationists have had a conflict between, does tea bag model work? Indian medical system works on tea bag model. 4.5 years they say is enough to accomplish the competencies that have been put up in the competency medical education. But what are these abilities needed to be a good Indian medical graduate? So for that, we have this competency-based undergraduate medical curriculum. All of us, though we are trying to deliver this, I'm not sure how much we have accomplished in delivering this curriculum. So here we talk about the new elements. which incorporate subject-wise subcompetencies. We are talking about alignment, breaking silos, breaking barriers, like how from physiology I can do a lot of things in medicine, radiology. And foundation course is established to tell the student what is it that is in store for him. We have the skill acquisition and certification, which was not there before. We have a lot of things like electives. So if I'm interested in a particular extracurricular component or in suppose a vocational, I have electives that are offered to me. It was considered that we have inbuilt, Indian Sanskar has inbuilt ethics that is taught to us from birth, but that is not the case. And so we have attitudes, ethics and communication being talked about as a curricular component, which is also assessed. And we talk about multifaceted assessments. I'll talk about assessments in my last 2 slides. So if you see here, you see the number of subjects, you can see we have 21 subjects, but look at the number of competencies outcomes, 2,949 outcomes. So it's quite intimidating for a beginner who enrolls into MBBS. You say at the end of 4.5 years, you have to be accomplished with 2,949 competencies. How do we do it? In what phases? So it has come up with a structure. Okay, you have this foundation course, then you have phase 1, phase 2, and thankfully, after a long time, we have won the battle where we are not called non-clinical teachers anymore. We are called phase 1 clinical teachers, phase 2 clinical teachers. So at last, we have got our identity. So to do this, it's not a difficult task anymore because you have all these modules that have been laid up. Whatever change that has been brought up, all you have to do is log into NMC and you find all these modules. So it's not that Vijayapura does it differently, Kolar does it differently. So all of us do it the same way because there's a rollout plan here for the UG curriculum, how it has to be delivered. And as far as assimilation of understanding this CBME has come up, we understand that we have moved towards application from acquisition. We used to teach a lot of 1.5 years of anatomy was taught. So, but now everything is taught in context with how much he needs to know as a surgeon when he goes back. So we have moved from acquisition to application. It is more learner-centered, as we can see. So a lot of things is, what is it that the learner learns at the end of the session? It's not enough if you say, as a teacher, I taught these things. It's important, what is it that the learner learned? The basis was structure. There needed to be a lesson plan, a structure, but now the basis is outcome. What is it that the student gained at the end of it? Assessment was final exam, pass or fail. But now you know that emphasis is on continuous assessment. How much incremental response is happening over his duration. Time was fixed time. Even now it is fixed time, but the idea is it will be a hybrid module. Suppose I attain 2,949 competencies in 3 years, I'm fit to be an Indian medical graduate. If I don't need 4 years, I might take 8 years. But the bottom line is 2,949 competencies or outcomes that has to be met. So these were the domains. The last domain that you can see, communication, has been added to this. And if you see our timetable, it's so much different from what it was before. You can see a lot of new things like sports and extracurricular activity as a part of our timetable. And you can see there is something called early clinical exposure. You have mentorship, you have Kannada language, you have a lot of things in the timetable that is registered. So our timetable has changed to reflect what are the changes that were offered in the curriculum. So physiology that was taught with 11 topics, 131 subject competencies. Of them, 131 were core competencies and 7 non-core competencies. And out of this 131 core competencies, we still have 119 of the competencies belonging to knowledge domain only. There are only 15 that belong to skill domain, that is shows how, and there were only 3 that belongs to performance domain. That means we still have a long way to go if we have to move from acquisition to application. So after all these competencies, basically our competencies were, if you take the Miller's pyramid, at the comprehension level. So if you can see this, we have 11 topics because all of us are physiologists. I thought I'll put up this table. We have 11 topics. If you can see, integrated physiology is something that has come up newly, which is important. And see the number of competencies. Most of the competencies you see in neurology, and then you see core and non-core. Most of them are core, very few non-core. You have only 6 non-core items, and that too most of the non-core are in CVS and some of them in integrated physiology. 5 of them are in integrated physiology. You mean to say desirable to know. And if you see the levels of domain, most of them are still in KH, knows how. Very few shows how. It would have been important if most of it was shows how. performance is very, very few. 2 in neurology and 1 in respiratory system. And then you can see how many of them are integrated. All these systems are vertically integrated and some of them are horizontally integrated. Most of the integration you see in, if you can see, in neuromuscular physiology and in neurology. So we have a lot of integration, the competencies are knows how, and we have most of them belonging to the core competencies. So we are planning to have a module with so many departments alongside. So it's not enough if the NMC comes up with competencies. Faculty started asking them, as well providing the competencies, why not give SLOs to us? Why not give us learning objectives also? That was a task taken up by the universities. They taught faculty how to frame objectives. So based on the competencies, learning objectives were framed and learning methods were derived from these objectives, and assessment methods were designed to ensure whether the objectives were met. So a lot of things happened in the last 4 years. So the teaching hours, if you can see how it is distributed, these were the teaching learning methods. Not that we didn't do it before. If you can see, the lectures were reduced, early clinical exposures, AITOs, SGTs, SDL, DOAP, lot of new things. If you see a person who has stopped teaching for 10 years and comes back, this looks like Greek and Latin to him. But this is not something new. Only the terminologies are new. As medical educationists, we need to know the jargon of what the medical educationists use. So you see that how it is distributed. Lectures, they say, are temporally aligned. ECE, you say you need to do it in the hospital setting. There are some challenges though. So the phases of medical education were in such a way that they were compartmentalized. So jumping from anatomy to surgery was difficult. So now there is a bridge by means of these integration programs. So you have integration with respect to, you have different names, sharing, correlation. Harden was the one who came up with these different phases. All of us in all universities are doing this sharing, correlation, nesting. And if you can see, physiology is aligned with so many subjects, anatomy, biochemistry, pathology, pharmacology, and internal medicine, pediatrics, and all of these. And most of the levels of integration that we follow are nesting and correlation. So if you can go, this is just in nutshell to make it easy. We have done this homework, but all of these are available in the modules. So you see that the certifiable skills, ours is the maximum. Physiology has the maximum certifiable skills and the numbers required to certify, which goes on to say that we need the maximum number of faculty. And the early clinical exposures, all of us choose different topics. And we have the skill training modules. We have been taught how to train. So we have been given the flow chart as to how to plan the skill session. We have the logbooks where the student documents his portfolio and we have to summarize whether these competencies have been met. This is something that as a medical educationist is very important to me, the Dreyfus and Dreyfus model of development, wherein we take the student through the milestone from novice to expert. Teaching is coaching, so the ad hoc model of medical education is like, how can we ensure graduates are competent in all domains? For this, what is important is the competency-based assessments. That is in a different ball game altogether. So maybe some other time, when time permits. And what I would like to say is, whatever research or component, any domain that we are talking about, what is important is how my Indian medical graduate is geared up for that role. So for that, what is the faculty's role in bringing about kindling interest in students? For that, we need to have a lot of training programs, and teachers have to have a broader vision and not myopic vision. Thank you for providing an opportunity. Though it's a whole different session, theme, which might not align with what is in store. I thought it was important to see that Indian medical graduates also have this in addition to what they have to acquire. Thank you so much.
Thank you, Dr. Vinita, for a very crisp and concise what is expected out of a physiology teacher. It was excellent. I'm sure there will be definitely people who would like to ask a lot of clarifications, and I'm also sure they are hungry. I thank her for the wonderful lecture. She'll be definitely happy to respond to them later. Thank you.
That was resourceful. Thank you, ma'am. Now, I request the chairpersons to present the certificate and the memento to the speaker. Thank you, ma'am. I seek Dr. S.S. Gowda, sir, to present the certificate and the memento to the chairpersons, Dr. Tejaswini Vallabh, ma'am, and Dr. Vidya Patil, ma'am. Thank you, sir. Thank you, sir.
With this, we come to the end of the first half of the session. I kindly request the delegates to proceed for the lunch, and I request everyone to gather back to the post-lunch session. Thank you, everyone.